Good morning, everyone, and welcome to today's webinar, ACS Trauma Verification July Q&A. Now, before we get started, I'd like to go over a few items so you know how to participate in today's event. Now, you are listening in using your computer speaker system by default. If you would prefer to join over by phone, that's okay. Just select telephone option in the audio pane, and the dial-in information will be displayed for you. Now, that being said, I would now like to introduce Molly Lozada.
Thank you. Thank you, everyone, for joining today's web conference. And I'm just going to go over some housekeeping things. So in today's presentation, Megan will be presenting a segment on the report process, just so everyone's familiar with that. And so it'll be Rachel and myself presenting as well. Continuing education, to qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim those. If you have any questions during the entire presentation, please email us at thecotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patients, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patients at your center. So with that said, we're going to go ahead and get started. Again, many of you are familiar with this. For those that are new, please download a copy of the Orange Book if you have not had the opportunity, or if you have a hard copy, that's great. Make sure that you are also using a copy of the clarification document and the change log. As I've learned, even as of today, I had a phone call. Many people do not realize that the book does not get reprinted. The book is the initial original book from 2014. Any changes to a standard criteria is printed in the change log, it's printed in the change log, and clarifications are noted in the clarification document. Again, the book is not reprinted. It is in its original format. And these are available on the website posted. We just released the recent monthly update. So if you did not receive a copy, go ahead and reach out to us at the COTVRC so that we can add you onto our distribution list. Just a couple of reminders for folks that are new to our webinar or new to the verification process or just simply new to trauma. Recordings of our webinars are on its own webpage, as you see here, the first link. And also, prior to the webinar starting, we do send out the PowerPoint to all participants who have registered. So if you did not receive a copy of the PowerPoint, we can send that to you shortly after the webinar ends. Just send us an email at the COT box. Again, the stakeholder website is still available. It's still open. We're still taking comments. Frequently asked questions is available. And again, anyone who's new to our process or new as a site visit can look at, check out our tutorials that we have set up. And then we also have a new participant hub, which Rachel will cover a little later in more detail on how to access that going forward to update your hospital's profile. All questions are pulled directly from the questions submitted. There have been no edits made to the content. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. Also, what's not on here is that if your question is not on today's webinar, again, it could be that we've covered it in previous webinars and we'll direct you to where that information is housed. So I'm going to transfer this to Rachel for scheduling reminders and updates.
Good afternoon. We'll start with the site visit application. As some of you may or may not know, the site visit application is now online only, so there's no more printing, no more paper, no more faxing. It's all electronic. And this can be accessed on the ACS Trauma website pages, as you see below, at the VRC site visit application, or on the Trauma Quality Program Participant Hub Account Center. So if you click the links, it will take you to the Account Center page. On that page, you can log on And just wanted to let you know, this login is not the same as your PRQ login. In order to log on, you'll use your username and password that were emailed to you when you started the process of joining a trauma quality program. So for example, for those who participate in TQIP, this is the same password you would use to access the TQIP education portal. So once you log on, the first page you'll see is right here, that second photo. And you can go down and request the site visit. You can click on that, and the application will just drop down. So now the online application must be submitted at least 13 to 14 months in advance of the requested site visit dates and must be before the expiration date. You'll also see that there's, we're asking for the preferred dates. You could add that right in there, as well as on the application, you can request for an alternate pathway. And the alternate pathway is for surgeons and physicians who trained overseas and want to participate on the trauma call schedule. Their CVs must be submitted to the COTVRC@facs.org inbox, as they will be vetted by a subcommittee for eligibility to go through the alternate pathway. You'll see also down at the bottom of the page you can access the orthopedic trauma liaison application. And for all level 1 trauma centers, you must complete this OTL form and submit it to COTVRC@facs.org with a copy of the OTL's curriculum vitae. So at this time, we are accepting applications for May 2019 and onward. So pre-review questionnaire, PRQ online access. Once the application has been submitted, the VRC office will provide you with an email receipt of confirmation. Right in that email, you'll receive your PRQ logins, and you'll be able to access your PRQ from that point on. The online PRQ can be accessed at the following website, and a copy of the PRQ in Word can be downloaded at the following website as well. So we're asking you not to submit your payment until you receive an invoice for the site visit, and you should receive that invoice like 30 to 60 days before the site visit. Then your center will be billed annually for the trauma quality program fee, and you could see a fee structure over at the website listed. Now, scheduling site visits. Visits are being scheduled quarterly. So as you saw in the electronic application, we ask that you provide us with the exact dates you would like to have your site visit. Now, if you've already sent in your application and received your receipt email with your logins, then your visit is in our system and you're actually set. So no need to apply online. But if you did not add the exact dates on the application, please go ahead and email it to me. The visit will occur on your chosen dates, but we may ask for different dates if the review team cannot attend the requested dates. Once the review team has been secured, you will receive a confirmation email that will include your reviewer names and all their contact information. And you should receive the confirmation email approximately 120 days prior to the scheduled visit. The ACS travel agent will arrange the site reviewer's flights, and reviewers will make travel plans approximately 20 to 30 days prior to the site visit. The hospital is to arrange and pay for the site reviewer's hotel accommodations as well as their ground transportation. And we ask that you contact the reviewers directly within 30 days of the site visit for their flight itinerary and any logistical information such as hotel, ground transportation, etc. So we did have one question that came in about site visit dates. It says, I have an application in for a site visit in late January 2019. Can I still request specific dates, or will it be in the date range? I did cover that, but definitely yes. please email your specific dates to me, rtanches@facs.org. Thank you.
Thank you, Rachel. And we are going to move on to the next segment, which is site visit report, and that's going to be covered by Megan Hudgens.
All right. Hi, everybody. I'm Megan Hudgens. I'm one of the 2 program coordinators for the VRC. And what that basically means is I'm one of the people that helps to process your site visit reports. So today, I really just wanted to give you kind of an overview of how the report process works and give you a clue as to what happens to your report between the reviewers leaving the on-site visit and you receiving your nice, polished final copy at the end of the process. So, as you probably already know, there is an extensive process of peer review that comes after the review team finishes the rough draft. And this has a few different purposes. First, on a base level, we want to ensure, obviously, grammatical and stylistic consistency. We do have multiple people contributing to the same document, all with their own ways of writing, and it's important to us that the final product that we return to you doesn't read that way. Secondly, we want to verify any deficiencies, if there are any, that are noted in the report, that they have adequate justification for their presence. Our goal is that you should never feel like a deficiency just emerged from the ether apropos of nothing. Nothing in the report should ever be a surprise to you. And lastly, in the process of having more eyes looking at the document, it allows for additional perspective and just suggestions of additional strengths or opportunities for improvement or recommendations. So, excuse me, the first thing that I wanted to do is to give you kind of an overview of how the report is crafted. So what you're looking at right now is a screenshot of our online report writer system. And with the current system, a lot of the work is actually already done for the reviewers before they even reach the hospital, based on how you complete your PRQ. So if the system notes any deficiencies based on your PRQ answers, a lot of the yes/no questions that are tied to CDs, it will auto-populate right at the start of the report, as you can see in the left screenshot. And we always ask, of course, that reviewers validate those just to make sure that they're consistent with what they're finding at the site. And at the end of every chapter, there are the text boxes that you see on the right side of your screen. And every reviewer, after being assigned their section, will fill these out for their chapters. After they've saved their progress, what they wrote will auto-populate into the executive summary. So after all members of the review team have completed their sections, the lead reviewer will export the report from the report writer system and save it as a Word document and send that along to us. And the report will be taken by either me or my fellow program coordinator, Bumi Parikh, who will manage the flow of the document through the whole process. So first, we review the report just on a basic proofreading level, grammar, spelling, the Oxford comma, very important to me particularly, formatting, and so forth. We do a bit of basic fact checking and ensuring that any deficiencies or opportunities for improvement currently cited have recommendations. And after we've completed our review, we'll pass the report along for additional peer review. So there are a few different groups that review the process, they review the document throughout the process after we get our hands on it. The first is one of our clinical editors. And our clinical editors in this case consist of a panel of 6 people. They're all reviewers, and they do a close read of the report for any content-related questions. They have 7 days to review the report, and then they send it back to us with any questions or suggestions they have for improving it. So once we've received the report back from the clinical editor and any changes therein were agreed upon or are declined by the lead reviewer, we implement those, we finalize the report, and then we send it along to the verification review committee. We have a pretty big pool to draw on for this. So to move things along fairly efficiently, we've actually split the committee into 3 subgroups. We call them tally groups, among which we distribute these reports. And each group has about 18 members. They all have 1 week to review the report and discuss through email. And the lead reviewer is copied on the email thread so they can answer any questions or requests for clarification. So after 7 days, provided that we have at least 5 responses from our committee members and there's no discussion that's currently ongoing, we send the final report to one of our VRC chairs. We also include a transcript of the discussion for with the tally group. And at this stage, the report is usually pretty much done. It's usually finalized without much additional deliberating. The chair, of course, may have questions of their own that they need to resolve with the team. But either way, the chair will ultimately decide that the report can be sent as is, and that is when we can prepare the report to be sent to you. So on the whole, this process takes about 8 weeks or 2 months from start to finish. I will note that this is an estimate. There are definitely things that can make this faster or slower. Usually if you were undergoing a consultation or a combined adult and pediatric visit, that'll bring a little bit more processing time just because there's more report for us to process. On the whole though, 8 weeks has been about our average, so that's more or less what you can expect. Upon adjudication from the VRC chair, we'll apply a cover sheet to the report and write up a final letter. Both of these will be distributed through email, which brings me to another important point. Please let us know if you have any staffing changes or updated contact information so that we can make sure that your report gets to where it needs to go. We try to keep our internal records pretty consistent and up to date, but you'll just want to let us know if anything changes at your center. And that's kind of it. Again, this was Megan Hudgens, Program Coordinator. If you have any additional questions about your report, feel free to reach out. We're happy to help. And I'm bringing this back to Molly with announcements.
Thank you, Megan. One of the things Megan may have covered pretty quickly is, and you'll probably see emails from Boomy and Megan. They go out, and we're going to have a segment on PRQ challenges and just some tools of the trade, really, until we have a new PRQ. Is that you may hear often from them just clarifying some data that was reported in the PRQ and it just didn't get updated, and it may have been updated with the site reviewers on site, but it never made it to the report, hence why you'll see emails from Boomy and Megan just asking to clarify maybe some data tables or some questions that may have not been answered correctly. So just keep that in mind, that that's the reason why we go through this thorough process, and they're just spot checking things as well. So just to go over some announcements, our next webinar is scheduled for August 30th at noon Central Standard Time, and the deadline to submit questions will be August 15th. Again, just want you to save the date for TQIP. The conference is going to be November 16th through the 18th in Anaheim, California. Hotel reservations are now open, and also pre-conference registration is also open for those folks that are looking for possibly an optimal course or AIS course, etc. There's a list on the website. I also want to make an announcement that the NTDB call for data is open. The ACS COT annual call for data is now open and will end October 1st, 2018. During this call, we are accepting admission year 2017 data. TQIP participants are not expected to participate in this call for data and should follow the regular quarterly data submission schedule. Centers with upcoming consultation or verification visits will not have to pay to submit data. For more information or to begin the process of joining the annual call for data, please visit the website listed below for instructions. So we're going to go ahead and move on to PRQ updates and questions. PRQ online web access for you folks who are working on the web for the PRQ, please note that we are scheduled for maintenance on Friday from 7 a.m. to 11 a.m. Central Standard Time. So you will not have access to the PRQ, the online PRQ. So, you know, if you try to log in, you're going to get an error message. So I just want to let folks know. So again, we're doing maintenance, and part of that maintenance is updating the CME questions that due to the change of the CME question. So that will take place during the maintenance period. And again, just as a reminder, the appendices for the trauma medical director, pediatric trauma medical director, and anyone who has gone through the alternate pathway or will be seeking the alternate pathway CMEs, you know, you must complete those sections of the appendices for CME. I do want to cover the PRQ data tables. As I mentioned, these are the areas that we most often get questions on, or you as participants are seeing Megan and Boomy reach out to you asking to rerun your numbers or just clarify the tables don't balance. So I had a question come up, and I thought it was a good time for me to just kind of talk about it a little bit. So the PRQ, so here's the question. The PRQ instructions state to use the NTDS criteria, but that excludes patients discharged from ED, and the PRQ asks questions related to these patients. This seems contradictory. How do we reconcile these numbers? So I do want to answer that. In the PRQ, I always think of verification as its own little silo program. So we, VRC, look at it the same way as the NTDS criteria. So the PRQ, there is one line item that asks about ED discharge or patients discharged from the ED. And again, those are any patients holding for 23 hours or less. Typically we don't count those as admitted patients, so we're not looking for that number. We do want to know how many were released within 23 hours. So there is one line item, but in the table itself, as you see here, everything's color coordinated to what needs to match. And this is also noted in the PRQ guide that is sent to the program managers upon receiving their PRQ login access. So there should be a document attached to that. And we do cover these tables, and basically what we're looking for, and I'm sorry the pointer doesn't work here, but in the first table, number 5, where it says ED trauma visits, admitted ED trauma visits, we're only looking for those admitted to trauma, and we're not looking for the overall hospital. I know there's some veteran nurses that have been doing the PRQ for many, many years before my time, and it is true that before the Orange Book, then we were asking for the total number admitted to the hospital at large. So we did modify that to just want the number admitted to the trauma, ED trauma visits. And again, as you see here, the numbers anything admitted needs to match. Again, in table number 6, ED disposition, that's where we're asking for the discharge number. So again, that number doesn't need to match with anything. We just need to make sure that the ones that are color-coded match across the board. If anyone has any questions about this table, feel free to reach out to us, Megan, myself, or Boomi, or through the COT box. But again, it's also discussed in the PRQ guide manual. So we're going to move on to general questions. Alternate pathway criteria, I know Rachel talked a little bit about that. The question came in: if a neurosurgeon, and this applies to any surgeon, call member is FACS but not US boarded, are they then exempt from the alternate pathway requirement? So yes and no. So US or Canadian non-board certified surgeons who were inducted as a fellow of the American College of Surgeons, FACS, prior to January 1st, 2017, are not required to go through the alternate pathway process, so they're exempt. But if there are any new surgeons, or I shouldn't say new, but if there are any surgeons new to your panel who just recently were inducted as an FACS, they're required to go through the alternate pathway process. And that process is the same as with anyone who is not FACS, so they have to reach out to Rachel for that. If a surgeon is not trained in the U.S. but has completed several fellowships in the U.S., can he take trauma call if he is ATLS, and I'm assuming it's current in ATLS? So again, if there's a U.S. or Canadian non-board certified surgeon who did not train in the U.S. and who has not gone through the alternate pathway in the past, but has completed several U.S. fellowships, which is okay, they may be acceptable to participate on the trauma call if they have been approved by the alternate pathway. So you can't just put them on the call panel if they're not boarded, but they've completed fellowships. They have to go through this alternate pathway process. It will be a deficiency. It's a type 2 deficiency, so if it's the only CD you're cited, you still get verified for 1 year. But I just want to let you know that that is a deficiency, and that's true for physicians as well, ED physicians. What is the recommended staffing for a level 3 trauma program with approximately 900 patients per year? And the staffing includes trauma program manager, trauma PI nurses, registrars, etc. First of all, I want to say this is a lucky trauma center if they have trauma PI nurses. That's great. Most trauma centers do not have trauma PI nurses. That is not a requirement at this time. So we can't factor that in. And I do want to stress that the number of staffing at any of the levels 1, 2, 3 combined trauma centers will vary based on the patient volume and really on the resources available to that trauma center. But for the most part, what we can tell you is what's currently in the Orange Book that is needed, and that is a trauma program manager who can act also as the registrar. And again, this is for a level 3 trauma center. The TPM or trauma coordinator, or whatever the title is, may also act as the registrar. However, what I want to stipulate, and we've seen this come up in several reports, is that if the trauma program manager's role is encumbered by wearing too many hats or doing too much, and the trauma program is starting to get affected by the multiple duties that person is on, such as the registry, for example. And this is a perfect example. If they have 900 patients admitted, and I know it doesn't say that, but let's just assume that it's 900 patients admitted to their trauma center, the requirement for one full-time FTE for a registrar is 500 to 750. So therefore, this person or this particular center will need to have a separate FTE for the registry. Question about FAST exams. What is the requirement for performance improvement with FAST exams for level 2 and level 3 trauma center? So I do want to say there are no requirements regarding FAST exams. What happens during a site visit and also in the PRQ, it asks for what is the process, or in this instance, it's listed as a QI. So what is the QI process or PIPS process for administering the FAST exam, and who administers that exam? And it does not infer that a CD will be cited if you just say, oh, we currently don't have a process, or it's not written, or what have you. So it's basically more for the reviewers' informational purposes. And again, reviewers will ask that if they're going through chart reviews and there's a discussion about FAST exams. Operating room washout. So there's a question in the PRQ that asks for the average range of the time to wash out of open tibial fracture secondary to a blunt mechanism. So the question is, can washouts at bedside also be counted in that number? And the answer is no. We only want you to list those that occur in the operating room. So if there's a washout happening at bedside, do not include that number into the average and the range. Radiologist final reads. Has the ACS COT defined any timeline by which attending radiologist final reads reports should be completed on trauma patients? No. So we have not established a timeline by which the final read must be done. So again, that's something that has to be done internally and monitored internally. Documentation regarding ED and trauma flow sheets. In the ED for activations, we are on paper until after the CTs, at which time they switch to a DEMR documentation. Is there any recommendation to stay on paper if started that way, or length of time to do that? Was cited as a weakness at recent review. And we see this very often in a lot of reports for trauma centers who are doing their flow sheets electronically. And a lot of it has to do with the programming. It's not something that it's something that you have to be cognizant of how your electronic flow sheet works programming-wise, and the reason being is that based on how it's programmed, and this is how it's programmed pretty much for the majority of the trauma centers, is that it doesn't chronologically follow the care of the patient. So you want to be very careful with that. I was on a recent site visit, and we noticed that was happening. Patients getting discharged, and then the next thing you see is the patient had an operation. So you have to be really careful on how that's being tracked and monitored. So the VRC stance on this is that that the electronic flow sheet must contemporaneously document the care of the patient, meaning follow the care of the patient in sequence. Typically with electronic flow sheets, a date stamped at the time of a keystroke or even when the entry is made. So again, be very cognizant of the date and time stamp. If the reviewers see a number of instances where the date time is not accurately documented, then they may cite that as a weakness. It will never fault to a deficiency, but it will be cited as a weakness, as you have said in this question. Transfers to non-trauma center. During the June webinar, it was stated that it was acceptable for a trauma center to transfer neurotrauma. Please clarify. So I do want to clarify that in the June webinar, the response was for a level 3 trauma center, very different than a level 1. Level 3 trauma centers are not required to have neurosurgery capability, so very vast difference here. As a level 1 trauma center, it would be a rare event that the trauma center would transfer a neurotrauma patient unless patients were being diverted based on your contingency plan or diversion policies such as flooding, equipment failure, repair, etc., or discharged and transferred to a neuro facility for specialized care. But again, if it's an event that happens rarely, just make sure that you're documenting that through your PIPS process and monitoring that. Referring facility feedback. What specific information for referring facilities is to be inpatients charged for transfers to the trauma center? We've seen this question come up fairly often. Although it's not a requirement, it is essential for the responsibility. It is an essential responsibility of the tertiary facility to provide specific feedback to the referring facilities and pre-hospital providers if needed. The feedback should include final diagnoses, the general course and outcome of the patient, and any PI issues that the tertiary facility identified in the care provided prior to arrival and or transfer. So again, that feedback's important. I know that a lot of trauma centers don't provide that feedback, and I know that we've said that, and it's okay that if you document in the patient's chart that you've tried to reach out and contact the facility that you haven't received any feedback, to at least note that in the medical record. Transfer agreements. Are transfer agreements required between facilities that operate under the same corporate umbrella? Yes. So patients who are transferred to or from another facility, whether that is a sister hospital operating under the same license, a transfer agreement is required. The transfer agreement may include all of the facilities that it will transfer trauma patients to and from. So you can have one transfer agreement with all the facilities' names on there. So CD-related questions. Trauma surgeons. So the question is about trauma surgeon trauma call. Is it required that the trauma medical director also take trauma call? Yes. So the trauma medical director must participate in trauma call at CD 5-5. It's kind of like a two-part CD, so you want to make sure you pay attention to the last piece of that requirement. Is a departmental summary of OPP sufficient for the ACS review, or do you need an individual provider's OPPEs available for each department? As I mentioned before, the expectation is that the trauma medical director is conducting the OPPEs and has a process available to present on site. If asked, if the question is referring to the trauma medical director signing off on the OPPE for the specialty providers, that's all the specialty providers, the expectation is that the OPPE for all specialists should be performed by their respective directors with oversight from the TMD. Have available a copy of the documentation for each of the services. It is not required to have the OPPE documentation for each panel member at this time. And we have, I believe we have a couple of examples on the resources webpage of what those OPPE is. If it's not something that you're looking for that's posted there, we have some also in the office that we can share. Activation criteria. If an incoming patient is a traumatic arrest, should that patient be made a full activation, or is the activation level up to the MD discretion? So the activation for a traumatic arrest will depend on your trauma center's activation policy. So if it's a traumatic event or traumatic arrest, it's part of your highest level of activation, then obviously you're going to want to activate that. If it's not part of your activation and you're seeing an increasing amount of that traumatic arrest happening, you're going to want to look at your activation criteria for the highest level of activation, the limited tier. I will say that most often, if it's a traumatic arrest due to a penetrating injury to the chest or a gunshot wound to the chest, it may fall under your highest level of activation. At least if it's a gunshot wound to the chest, that's part of the highest level of activation criteria. So again, that's going to depend on your trauma center. If you're a combined level 1 adult and level 2 pediatric trauma center, do you have to have 2 separate program managers? Yes. So if you are in a verified adult level 1 and level 2 pediatric trauma center, there must be 1 FTE trauma program manager dedicated to each program. Meaning the adult TPM is dedicated to the adult portion, and then the pediatric program manager, the pediatric program may have a pediatric trauma coordinator, and that person may have additional duties as long as it does not encumber their duties as the trauma program coordinator, manager. The titles are interchangeable for us here at the college. It could be a coordinator, it could be a manager, it could be a director, whatever that is at your facility. So basically, the pediatric trauma coordinator in this instance could also serve as a trauma registrar for the pediatric program, or they can also be the injury prevention coordinator. So they can do any one of those tasks. Trauma program manager, CD 524, define clinical experience in the care of the injured patient. Are you requiring we become bedside clinicians? No. We're not requiring that you become bedside clinicians. The expectation is that the trauma center will credential the candidate to have clinical experience in the care of the injured patient. This may include job experiences, education or training, such as emergency medical technician, paramedic, a registered nurse, etc. It is not required that the candidate be a registered nurse. So that is not one of our criteria. We're just saying they have to have clinical experience. And then at the bottom of page 42 for the trauma program manager, it goes a little bit further into what those responsibilities will be. So maybe that may be some serve as some assistance as defining what this clinical experience may be. So it talks about clinical activities such as coordinate management across the continuum of trauma care, which includes planning and implementing of clinical protocols and practice management guidelines, monitoring care of the injured patients, in hospital patients, and serving as a resource for clinical practice. So again, that candidate will depend on what the credentialing process is for that facility. Trauma surgeons, peer review attendance. Are there any caveats regarding peer review attendance for rotating military trauma surgeons? So we do. We have established some criteria around this, and it's in the clarification document, I believe. Peer review meeting attendance may be waived for deployment, medical leave, and missionary work. The center must provide documentation to support the absence. So if they're partially deployed or partially on medical leave during the reporting year, you can also have that attendance prorated. I have a 2-part question for the upcoming July webinar. We are a level 1 pediatric trauma center attached to a separately verified level 1 adult trauma center. If adult trauma surgeons are primary responders for pediatric trauma activations above a certain age at night and on weekends, are all of the adult trauma surgeons required to attend the peer review meeting at least 50% of the time? That's the PED peer review meeting. The second part of this is, what if the roles were reversed, where the PED trauma surgeons are the primary responders and the adult trauma surgeons are providing a secondary backup call? So we have this in the clarification document as well. So the quick and hard answer is no. They don't have to each attend each meeting for the adults and for the peds. What we have established is that if you are in a combined center seeking verification or maintaining verification, there must be a representative that's preferably the trauma medical director, the pediatric trauma medical director, or another designee from the adult program or from the pediatric program attend one of the other's meetings. So the adult trauma medical director can attend the peds meeting, and vice versa, peds trauma medical director or assignee can attend the adult program peer review meeting. And should that happen, there has to be a mechanism by which you can present to the site reviewers that that is being done, number one, and number two, that any discussions resulting from attending those meetings is then relayed to the other panel members. So just want to make sure you can provide that information to the reviewers. In a level 1 trauma center, is a second call neurosurgeon required, or is a contingency plan sufficient? A level 1 trauma center must have a published neuro call schedule, so you need your primary call schedule. If the primary neurosurgeon is encumbered, such as with the trauma activation or they're in the operating room, then the contingency plan kicks in or is triggered. If you don't have a contingency plan, the alternative to that is having a backup call schedule. So it's one or the other. You don't have to have both, but if you have both, that's great, but it's one or the other. Does the ICU staffing patient ratio requirement apply to those patients that are housed, boarded, in the ED? Example is a patient came in and is to go to ICU for their injuries. ICU is full and not accepting any admissions. Patient is held in ED until a bed is open. Does the ICU staffing ratio apply to the ICU admitted patient physically in the ED? No. So the patient ratio is the patient to nurse ratio of 2:1 is for patients while in the ICU floor/unit. Until that patient is transferred to that floor, then that ratio kicks in. Because I would assume that the ICU patient is not going to be in the ED for very long. They're just waiting for a bed to open. That patient gets transferred up or over to the ICU floor. What place, if any, does or should cardiothoracic surgery have in the trauma PIPS program? So quick and fast answer is level 3 trauma centers are not required to have thoracic surgery capabilities. As a level 2 trauma program, is it essential that we have hand surgery service, or is it adequate if we have a solid transfer plan? Yes and yes. So a level 2 trauma center, again, very equivalent to a level 1. The services are the same. The only difference is cardiac. A level 2 trauma center is required to have hand surgery capabilities. The trauma center may have a transfer agreement in place for implantations, or, for whatever reason, the hand surgeon just doesn't have the proper equipment there, they can be transferred to a specialty facility. But there must be a hand surgeon available to consult at bedside for all other hand injuries. Continuous rotations, PGY 4 or 5. Please define continuous rotation. PG 4 or 5 for level 1 facilities criteria, specifically the expectations. Do they need to round daily, attend trauma conferences, respond to resuscitations, etc.? Thank you. The requirement is that there is a PGY 4 or 5 resident rotating on the trauma service. They should be rounding on patients, and any other requirements will be determined by the trauma center, such as attending trauma conferences and meetings. So again, as a level 1 trauma center, you should have residents rotating at the senior level 4 and 5, rotating on your trauma service, and what their role is will be defined by the trauma center. Is it a requirement for all injured patients to get a universal screening for alcohol or only admitted patients? I know we've covered this many times in our webinars, and and it still seems to be a little confusing for some people. So I guess the easiest answer is yes. So if you are admitting trauma patients to your trauma surgeons or neuro service, ortho service, it's regardless of the service, as long as it's a trauma patient, whether it's activated or not activated, and they have a stay of greater than 24 hours is how we're defining this. 80% of those patients must be screened, and that screening tool is going to be dependent on what you use. It doesn't necessarily need to be a blood screen, blood draw. It can be a screening tool that you've developed or one of the standardized screening tools. So again, it is eligible to patients who are alive and who can participate regardless of they're activated or not activated, who meet inclusion criteria with a hospital stay of greater than 24 hours, who are admitted to the hospital and entered into your registry. 80% of those patients must be screened. Injury prevention. What are the expectations for the number of injury prevention projects at a level 3 facility? For a level 3 trauma center, there is no defined required number of injury prevention projects. The expectation is, the expectation for the reviewers or for the trauma center, the reviewers will be looking or asking how is the trauma center helping its community with common causes of injury. So for example, if you're in an area you see a lot of alcohol or drug use among adolescents, what are you doing about that? Are you doing some prevention? Elderly care and prevention, seatbelt safety, etc. It could be anything. But what you want to do is you want to use your data from your registry to determine what is the most common cause of injury in your demographic area. And the reviewers will ask about that. Research, I thought this was a great question. Research requirement, please clarify for a level 1 seeking initial verification, if an author is no longer with the organization, can we still use if published within 3 years, period? So it depends. I didn't want to say yes right off the bat, but it depends. If the author is no longer with the organization, but the research publication was published while that person was there and they used your hospital's data, absolutely you can use that publication because it's based on your facility's data. So on the flip side of that, if the author moves, the research publication does not move with them. So because if it was used at your facility and they happen to move, it cannot be used at the new facility. So that's, I thought that was a great question. So we're going to just a couple of questions about CME. If an MD is not board certified in emergency medicine, do they need 36 hours of CME? My understanding of this question was if a physician is not board certified in emergency medicine, but is currently board certified in family medicine, internal medicine, or another specialty such as pediatric, they're not required to obtain CME. That is satisfied with them keeping their boards current or being current in their boards. Please clarify, do we need to make copies of each provider's CME certificates or just have a listing available? So again, I've gotten a few calls and people didn't know we changed the CME requirements. It has changed at in level 1, level 2. The only CME certificates that are required at the time of a site visit are for the trauma medical director or the pediatric trauma medical director, and or any surgeons or physicians who underwent review by way of the alternate pathways. Those are the only ones we're asking to have certificates available on site of a site visit. With new IEP rules for ortho, neuro, and ED, I'm taking this to mean the change. Our visit is October 2018. Do we have to show proof of IEP completion for the last 3 years? The quick answer is no. you don't have to go back. We're not going to go back 3 years. We're not going to go back a year. So if your ortho, neuro, and ED physicians are all current in their board certification, that satisfies the CME and the IEP process for the moment. However, if there were performance issues, and again, this is part of our language that were released in changing the requirement that the trauma medical director has the authority or right, however you want to look at that, has the authority to impose additional CME or impose CME requirements or IEP based on any performance issues. So if there were performance issues and say IEP was used to rectify those issues, then you do want to make sure that you have that available for the reviewers at the time of the site visit. Question about how should we address neurocritical care doctors with regards to CME. They're non-ABME. I think that should have been ACGME, but I could be wrong. Neurocritical care physicians are not required to comply with the CME requirement. So again, as long as they're current in their board certification, they satisfy the CME requirement. And that concludes our webinar for today. Thank you everyone for joining our call.
All right, everyone. Thank you to today's presenters and everyone for attending today's webinar for ACS Trauma Verification July Q&A web conference. Now, on behalf of the Trauma Verification staff and our presenters, thank you for joining us today, and all of you have a great rest of your day.